Hello, welcome to this tutorial on necrotizing enterocolitis brought to you by T2L London. My name's Sophie Rhys-Evans and I'm an intercalating student at Imperial College London. So what we'll cover today, we'll go through a case study and then we'll discuss the risk factors, symptoms, investigations, management, and then we'll finish off with a quick SBA at the end. So first of all, the case study. A female infant was born by NVD at 28 weeks, weighing 920 grams. The pregnancy was complicated by preterm premature rupture of membranes and preterm labour. So APGAR scores were 6 at 1 minute and 8 at 5 minutes of life. Remember that premature rupture of membranes refers to the rupture of membranes at least 1 hour before labour has started. If the rupture of membranes occurs before 37 weeks gestation, then this is then termed preterm premature rupture of membranes. Okay, so let's discuss the case first. So let's recap how the team would have managed this mother. So she would have been given corticosteroids such as dexamethasone. This helps the lungs to mature. We're discussing NEC today, but breathing problems, remember, are the main cause of death in the preterm infant. So it's really important to try and prevent when the mother goes into preterm labour. She would also have been given prophylactic antibiotics such as erythromycin. This reduced the risk of perinatal infection and sepsis, specifically caused by group B streptococcus. Magnesium sulfate can also be used to provide neuroprotection, reducing the risk of cerebral palsy, etc., but this is less well established. Okay, and what complications is this preterm infant at an increased risk of? So have a quick think, pause the video. So in general, I know we're covering NEC today, but let's remember that respiratory distress syndrome is quite a common cause, a complication of prematurity. Pulmonary hyperplasia, patent ductus arteriosus, NEC, as we'll discuss today, sepsis, intraventricular hemorrhage, cerebral palsy, retinopathy of the newborn. There's just so many complications, so we want to try and manage these as best as possible as early on. Main thing to appreciate is that all organs are immature in a preterm infant, so you must support them accordingly. Complications for the mother, you want to think about chorioamnionitis and sepsis. Okay, so let's focus on NEC. So after 10 days in NICU, the infant is not tolerating her foods. You notice her stools are bloody and her abdomen is distended. You take observations which show the following. So she's tachy, she's got tachypnea, and the temperature is slightly raised. Okay, so clinical presentation. Have a pause the video and think about what sort of things you'll be looking out for NEC. Okay, so these are the most common features, quite vague, but you want to rule out NEC as it can have quite a high mortality. The etiology of NEC is poorly understood. It may be due to a combination of factors such as bacteria, ischemia of the and necrosis of the bowel loops, poor bowel motility, and reduced nutrition. So those are more common clinical presentations. The presentation can then progress to the following. These, alongside unstable vital signs, suggest a very ill baby, and you want to start thinking about bowel perforation and sepsis. Okay, so investigations. This can be split into imaging and lab workup, but imaging is the mainstay of investigation for NEC. So you'd want to do an abdominal X-ray. An abdo ultrasound is used a bit less. So an abdo X-ray, these are quite niche signs that you may not be expected to know as a medical student, but it's good to understand. So pneumatosis, this is a diagnostic finding if NEC is suspected, and it describes the air within the bowel walls. Pneumoperitoneum implies bowel perforation as well, so you want to look out for that. That indicates a severe NEC, advanced NEC. CBC, you also want to look for low blood counts as well. And then this is just a abdo X-ray. Just from glancing at it, you can appreciate that the baby is quite unwell. You can see dilated loops of bowel as well as lines and tubes. So number 1, this is pointing to portal venous gas. So this is seen as a shadow under the liver, kind of like a branching of a tree. Number 2 shows pneumatosis crescens. This is a curved appearance of the intramural gas, and this is pathognomic for NEC. And number 3 is trying to elicit soap bubbling. This is due to submucosal gas, Again, as a medical student, you wouldn't be expected to know this, I don't think, but it's just good to have an understanding, and it's just quite interesting to see the differences that you'll be looking at. So in terms of management, this is split into 3 stages, Bell's staging criteria, and you can determine the management based on the clinical signs and the radiological signs. The key differences are the radiological signs, so pneumatosis, which is pathognomic for NEC, that's seen in stage 2, as well as portal venous gas, whereas pneumoperitoneum and ascites, indicating bowel perforation, is indicating an advanced stage NEC. So let's put this into practice. So based on the presentation and the signs you may see, what do you think the management would be, the initial management? Have a pause of the video and have a think. Okay, so first of all, medical management is applied to stages 1, 2 and 3A. This is predominantly stopping their oral feeding, commencing parenteral nutrition, and commencing broad spectrum antibiotics. If there's any metabolic acidosis or hemodynamic instability, then you want to be correcting that as well. But that progresses as each stage progresses. So the difference between 3A and 3B is essentially if there's bowel perforation. And for bowel perforation, you would want to manage that surgically by removing the necrotic bowel, and stoma reversal usually occurs a few weeks after the first operation. If the baby is too unstable to undergo anaesthesia, then a Penrose drain can be placed using a local to try and decompress the abdomen and irrigate the bowel contents. In terms of antibiotic therapy, you'd be looking for broad coverage, so maybe ampicillin, gentamicin. So yeah, that's how the management's split up. Okay, so complications, always important to consider. NEC is responsible for 10% of deaths in NICU, with mortality being higher in smaller infants, if they're more premature, and those that require surgical management. Having a look here, so short bowel syndrome can develop if a lot of necrotic bowel has been resected, so if they were stage 3B. This can possibly cause nutritional deficiencies and poor development later on in life, so you want to look out for that and manage accordingly. Okay, so we've discussed the clinical presentation, risk factors, investigations and management. So we're just going to apply that with an SPA. So a 9-day-old preterm neonate stops tolerating his cow's milk feeds given by the nurses in NICU. He vomited after the most recent feed and the nurse noticed bile in the vomit. Stools are normal consistency, but the last stool contained fresh fed blood. On examination, he is well hydrated, but his abdomen is grossly distended and an urgent abdo x-ray is requested. This x-ray shows distended loops of bowel with thickening of the bowel wall. What is the next best step in management? 1. Continue oral feeds, switching to breast milk. 2. Commence broad spectrum antibiotics. 3. Commence IV fluids. And 4. Commence IV hydrocortisone. So, have a pause of the video and have a think. Okay, so the answer is commence broad spectrum antibiotics. If the vital signs are unstable, there is a new peritoneum or medical management has failed, then you would consider surgical management. You would actually want to stop oral feeds and switch to parenteral nutrition. So the number 1 is wrong. Number 3, them saying that he is well hydrated suggests against that answer. It's not what they're looking for, but it could be a reasonable step if they did look dehydrated. And IV hydrocortisone is not indicated in this management. Okay, so the summary: prepare for complications in a premature infant and treat early. Key signs of NEC are feeding intolerance and abdominal distension. Investigate with an abdominal x-ray, and management is based on clinical and radiological signs as per Bell's staging criteria. So the feedback link is in the top graphic. I'd really appreciate any feedback you have, good or bad, really, really useful. And then this link is a link to my Twitter if you want to follow me or if you have any questions or anything like that. Thank you very much, and thank you to Teach to London. Please subscribe to the channel to stay updated with the latest tutorial. Thank you.